Well, I always said that, getting a scanner doesn't make you a better dentist unless you use what the scanner is giving you to learn. Because all you have to do, if you've never done it, and you prep and you scan and you think you made this miraculous, beautiful, smooth prep and you see it scan, you're like, ooh. It's always a little shock that your preps maybe aren't as good as you thought. In the beginning, I'll tell you, it's a hit to your ego.
Welcome to the Phil Klein Dental Podcast. Many of us out there who are listening to this episode are using an intraoral scanner, or they work in a practice that has one. The question is, are you doing everything clinically around that scanner to get the best results, taking advantage of this remarkable technology? To address that question and talk about the intraoral scanner as it pertains to our clinical procedures is our guest, Dr. Chris Pescatore. Dr. Pescatore is a general dentist who has been a pioneer in digital dentistry since the early 90s and has, according to him, seen it all when it comes to creating aesthetic restorations. He maintains a full-time practice dedicated exclusively to aesthetic restorative dentistry, and that's located in Danville, California. We'll be getting to our guest in a second, but first, for the optimal bond between zirconia and your resin cement, check out Bisco's Z Prime Plus. Rated best in class by thousands of top clinicians, Z Prime Plus featuring MDP creates a strong, reliable bond to zirconia, metal, and alumina substrates. And nothing could be simpler. It comes in a single bottle, and it's 100% compatible with both light-cured and dual-cured resin-luting cements. It's time you get the most out of your zirconia restorations. To learn more about Z Prime Plus and the entire Bisco adhesive product line, visit bisco.com. Dr. Pescatore, thanks for joining our show.
Thank you for having me. It's always great to be on these podcasts with you.
Yeah, we're really happy to have you on the show, Dr. Pescatore. Your previous podcast episodes with us are doing very, very well, high engagement. Lots of really good insight are coming out of those discussions. Today, we're going to be talking about the intraoral scanner. So to begin this episode, talk to us about the technique of scanning. What are the clinical implications, and which particular technique, if any, do you prefer?
That's a great topic right now, because when I first learned scanning, there was definitely a protocol, the way you go around the arch and all those things. The scanners have gotten so good. I actually go over the different scan protocols because I did them in my office and I actually found no difference, which was amazing to me. No difference in the first pass or how long it took, because in the corner of my monitor, it says how long it took. And it was a minute for each of them, just under a minute for each protocol. And, the first protocol, when they're doing an arch, people will start with the most distal tooth. And the one is, I call it the buccolingual approach, where you kind of just keep going buccolingual around the whole arch. And then that's your first pass. And then you go back to get more tissue. And then there's that, what I call the standard approach, which seems to be very commonly taught, is going on the occlusals around the arch and then going lingual and getting the whole lingual surface on the arch and then flipping it buccal and then getting buccal.
Right. And on the anterior, on that technique, on the anterior, you kind of flip lingual buccal between canine to canine.
Right.
Because of the incisal edge. Yeah.
Absolutely. Because when a tooth is thin, you want to get a little bit of buccolingual data. So you rock the scanner back and forth when you're doing that to get a little of both. And then the last one called the X technique. And a digital manager for one of the biggest labs kind of started it years ago. It's called, and his name's Eric Hill. And he and I were talking, and he goes, "Try this technique, see if you like it better." I call it the I call it the Hill technique because it's him, but it's called like the X technique, where you start the pass the same way on the occlusal, where you go from the occlusal all around to the occlusal of the opposite side. Then you go buccal. And as you go towards the midline, you cross over to the lingual and get the lingual. Then you turn it to the buccal, go the buccal to the midline, cross over and go lingual. And I found with that technique, there's a lot less wrist flipping and it was much easier to do. So I pretty much use that most of the time, but if not, I'll usually use a buccolingual approach. I know I've seen people say, look, this one's this much more accurate and this more accurate. I think clinical significance is it's not there for
How
this.
do you measure the accuracy? How do you measure the accuracy of these techniques?
Well, with my particular scanner, there's a heat map. green, you got the data. Great. So I use a heat map and you can see you're getting all the data.
All right. So you see
Um,
where you're missing. You just see the
you
missed
see,
spots. Yeah.
right, right. And you can turn the heat map on while you're scanning, after you're scanning, but I show in the video in my presentation the heat maps after the first pass of each. So you can see each one gets a little more of certain areas. And then you can see when you go over to get all the rest of the areas, the total time is, I think it was like 53 seconds almost for each of them identical. It was crazy. I think accuracy wise, sure, someone might come up with a stat from some research article done in some clinic or some, but in real life clinical, I think as long as you're not over scanning, I think either of those three protocols is totally fine and what works for you.
So let's talk about those dentists that are making that transition from traditional impression taking to digital scans. Does anything change regarding the clinical nuances, such as burr selection, prep design, tissue retraction, all the things that we're doing now, what we used to do, or most of us, for those that have switched to digital, used to do? What's
Right.
the big thing that we have to keep top of mind to make sure we're doing it maybe a little differently now that we're using the digital workflow?
Well, it's not just a digital workflow, it's also the change of our materials, especially with the advent of something like zirconia. But the most important things that come through are prep design and tissue management when you're talking digital scanner. I always say it's easier to take an impression and capture accuracy than a digital scanner because if you haven't retracted that tissue completely, you're not going to get the margin. Versus if I have an impression tip, I can actually put that tip in the sulcus and syringe my material. And guess what? I've just used the physical attributes of that impression material to aid in my accurate impression. So dentists have to be very aware. That's why great conservative dentistry, which is mostly equa or super gingival margins, is perfect. But we're doing a lot of re-restoring of teeth now. So you have to be really good at managing tissue. That's why I love soft tissue lasers. I've had them since the late 90s. They're amazing, the diode lasers. And you have to be really good with retraction, whether, cord, pastes, using combinations of, just so when you actually are physically looking at your prep, you can see the whole margin because that's what the camera is going to see. But that's also a great thing about using a digital scanner versus taking an impression is if I scan and I see, oh, I didn't really get it, I can just wipe that part away, retract the tissue or laser the tissue, rescan it, and there I have a perfect crisp margin.
Yeah, I'm going to talk to you about real time feedback in the next question.
Mhm.
But still on this one, you talked about tissue retraction. I don't know how many dentists have soft tissue lasers, or if they do
Right.
have them, how many have picked it up in the last 10 years they sits on the shelf. It seems to me that would be something they would use almost all the time for indirect restorative dentistry. That laser would be ready to go. But I'm finding when I talk to dentists, many of them do not use a soft tissue laser, although the ones that do swear by it.
Right.
What's your thought on that? Why is that?
Um, I don't know because like I said, I think the first time I used one was like 97, 98.
Do you use it for most of your indirect work?
A lot of times. Yeah, because if there's slightly inflamed tissue or if there's a little tissue and you're not using it aggressively, I think maybe that's the big hang up is people think it's very aggressive. You don't have to be aggressive with it. It's very simple to use just to create that little bit of separation from your margin to your gingival tissue. It's not a big deal. But also, there's nothing wrong with the standard way of retraction cord. Retraction cord is a great thing. I use that 90% of my cases. In addition, maybe I lasered before,
And
but
what about prep design for the digital scan?
well, studies have showed that chamfer shoulder margins are lead to the strongest restorations. If you're coming from a PFM background, which almost all of us are, we were taught that bevel, the long bevel, we always called it the infinite margin, kind of thing. Your lab basically determined where your margin was, right? So that doesn't work with the ceramic materials we have. It just doesn't work. And that's where you get your fractures or chipping, or that's a harder thing to insert. Sometimes there's insertion issues, so you have to get really comfortable with chamfer and shoulder margins. And I was doing them back in the PFM days, so I never did the infinite bevel. I was even with PFMs, I was doing a chamfer or shoulder and having the metal cut back, and my margin was all porcelain. So I always use porcelain margins on my PFMs anyway. So I think just getting comfortable with that, it's just a slight burr difference in selection, but I don't think any dentist will have a problem. It's just they have to know that they do have to change because of the materials.
We'll be getting right back to our guest in a second, but first, as a dental healthcare professional, you might already know that 3M Healthcare is now Solventum, and one of its next generation products is 3M ClinPro Clear Fluoride Treatment, available in a new rosin-free water-based formula. With soluble fluoride ions immediately available to deposit on the tooth, ClinPro Clear Fluoride Treatment needs only 15 minutes of contact time. Plus, with less waiting time to eat or drink after application, it's even easier for your patients to say yes. Its uniquely designed LPOP delivery system ensures a smooth and professional application process. In clinical studies, hygienists found it fast and easy to apply, and patients rated their experience an impressive 98 out of 100. So if you're looking for effective fluoride uptake in a rosin-free, water-based formula, try 3M ClinPro Clear Fluoride Treatment from Solventum. To learn more, visit solventum.com. Yeah, so that covers the prep design, and obviously that goes along with the burr selection, like you just said, to get that finish margin of being a chamfer. So when we scan, we're getting real-time feedback, and that's a completely different scenario than traditional impression taking. Although, when you take your impression, you do get to see it. But when you're doing the scan, that feedback is right there in your face. So talk to us about how that immediate digital feedback helps us as clinicians and ultimately improves clinical outcome for our cases.
Well, I always said that, getting a scanner doesn't make you a better dentist unless you use what the scanner is giving you to learn. Because all you have to do, if you've never done it, and you prep and you scan and you think you made this miraculous, beautiful, smooth prep, and you see it scan, you're like, ooh. It's always a little shock that your preps maybe aren't as good as you thought. And I know I went through that, and it may be just better. So you get better at preparation design. You're using the feedback. But like I just said before, if you see you didn't catch a margin, before you have to take a new impression. So it's another 4 and 5 minute impression in someone's mouth. You can just wipe it clean in the scan data, erase it, and then do whatever you have to do to expose that margin, rescan it in 2 seconds, and you're done.
So
that's a benefit.
Yeah, that's a big benefit. So the psychology when you're getting into digital scanning and now you're starting to cut the preps on a regular basis, in the beginning you saw the feedback and made your adjustments. Did you find that those adjustments developed into your technique where after a while that digital feedback that you were getting, you didn't need to do anything else? And after 6 months of using a digital scanner, you went, hey, my preps are, even under the digital scan results, are looking pretty damn good.
I'd like to say, yeah.
Depends on the day, right? Depends on the day.
I'm human like anybody. I mean, I don't,
right.
I don't possess any skills better than anyone else. It's just how hard you work at them and how hard you want to perfect them. And so for me, when I see some little irregularity, I'm going to go back and smooth it. Is it going to affect the life of the restoration if it was made to that other margin? Maybe, probably not. Who knows? But it's just, it makes you better if you want to be better. And it gives you the feedback available. In the beginning, I'll tell you, it's a hit to your ego. And I thought, geez, I thought I made these nice preps. So you can get better. You can get better.
Now, talk to us about the lab a little bit. In the old days, if your preps weren't ideal, like you just talked about, you didn't necessarily either know or want to take another impression. We relied on the lab to do a lot, right? To make it
correct.
And they kind of assume things. They kind of approximated things. So obviously what they did may not be the reality of what's actually in your patient's mouth. So do you find that the adjustments that you need to do when you get the final product back from the lab, and I know you do some milling chairside, but assuming you're sending it out to a lab, what are you looking at as far as redos, God forbid, or just things that aren't fitting the way you would like? Are you seeing way less of that since you've got into intraoral scanning?
That goes into a really big topic of how the labs have changed too. I've used the same laboratories for most of my career, so I have a good relationship with them. I know who I'm using at the laboratory. I can talk to them. That's really important if you're going to do cosmetic cases by far. And their people at the lab are actually CDTs now using digital tools versus what is going on now with the majority of the labs is they're hiring people off the street and they're training them on digital software. They really don't have tooth knowledge. And that shows when you get a restoration back. Anyone could put a library tooth on there and make it fit. I remember I was actually at a very big laboratory and they were giving me a tour and I watched somebody, they had a stone models, the technician, they put it in the scanner next to them. It popped right up on the screen, blah, blah, blah. They did a couple of things and they shipped the restoration off to the mill. And I looked at the person giving me the tour. I go, how long does that take? And they go, 3 minutes. They knew right off the bat, 3 minutes is pretty much what they're giving their technicians to make a tooth and send it to the mill. And I thought, wow, you're going to get what you get. And that's the problem if you're a CDT, if you're a certified dental technician, and then you're adapting digital tools, you still have all that knowledge of dentistry, of occlusion, where not to put interferences, how arches should look, things like that. But if you just know the software, I don't care how much they show you on dental anatomy, you're not really picking that up. I'm sure there's some that are very good, but I'm talking about the majority because you can see it in the restorations you get back.
Yeah, so that's what I was going to ask you. You have a relationship with your lab, so you're seeing really good stuff come back to you based on who's doing the work. And they're certified dental technicians, and they are also design software guys and gals, I assume.
Yes.
So how does a dentist discern between one lab and another when they first start the relationship with a lab? Let's say a dentist is leaving a DSO, he's becoming an associate at a dental practice. Now he's working with their lab, and now he's getting these cases back. What should he be looking for to, nip it in the bud so that he or she could fix the problem?
Right. Well, I think the first thing you can look at, and it's not definitely always going to be the only factor, but if you look at price, if you're getting $100-something crown, you're getting $100-something crown. If I get a $350 crown, guess whose is better? Not saying always, but you kind of get what you pay for. So you can kind of tell, and usually, and I'm not criticizing anyone's business model because there's some exceptionally successful laboratories that are very large and good for them and God bless them, but they have a certain business model. Smaller laboratories don't have those business models because it's more artistic. And I know some people, artistic. Well, hey, it all depends. What do you want in your mouth? And, so that's always very interesting. I always find people criticizing, and they usually criticize because they can't do it.
Mm-hmm.
I can't do a lot of things. I'm not criticizing anything because I can't do a lot of stuff. So I think you have to, for a young dentist, what you can easily do? You can go on Instagram and you can see people's before and after cases. I've done this where I saw this one dentist out of Chicago and I saw his case. He's a prosthodontist and I saw his cases and I thought, wow, that ceramic work is absolutely gorgeous. So if you look in their bio and their links a little bit, all of a sudden I see a lab technician. And I contacted the lab technician. I said, hey, I'd like to sing you some cases.
Unless that lab technician is in-house, then you can't work with them.
Right, exactly. But this, obviously, he wasn't.
Okay.
But if they're in-house, but, I've toyed the idea of bringing an in-house technician too, but I actually like making them myself, so I don't. But
and you also had a very large practice that you scaled down because you found that because of the size of the practice and the volume, you couldn't produce the kind of dentistry or have the lifestyle that you wanted. So you cut back.
Well, right. When originally on the East Coast, I bought a practice with over 10 employees, 6 days a week. I found Sunday, I just wanted to stay in bed all day. I did that for a couple of years and I realized I'll get out of dentistry before I keep practicing like this. I wasn't as proud of the dentistry as I thought I should be. So I made the decision at that point to explore in dentistry the more cosmetic restorative things, educate myself. And then I realized, so I dropped my staff from like a little over 10 to 5. I went to working 4 days a week or 4.5 days a week. In the late 90s, I moved out to California. So after I sold that practice, I started this practice from scratch with no patients. And I was able to, at that point, to say, this is the way I'm doing it. And I've tweaked it over the time, but I've always maintained, I mean, at the most staff wise, I've had 3 staff members at the most.
Yeah. I mean, the bottom line is you found where you found your comfort zone, where you wanted to be as far as your career,
Right.
and happiness and career satisfaction plays a big role in
Right.
our lives, not only our professional lives but our personal lives. You end up taking it home when you're unhappy from the office, and that's not good for anything. And I think part of the enjoyment you've gleaned out of dentistry is embracing new digital technology as it emerged. I mean, I think you've tried just about every gadget that they've come out with.
I've tried a lot of them, not all of them, but I've tried a lot of them. And I would say to this to Dennis, don't worry about what other people think of you, other dentists. I was listening to a podcast or a webinar once, and this guy was criticizing smaller practices like mine. Oh, with these little boutique practices. Well, here this guy ran a huge practice, and he was talking about how he wants 4 hygienists going at one time, and this and that. And I'm sitting there going, I'd love to see your cosmetic cases.
Hmm.
Just curious what they look like. And I'm not criticizing that either, but don't throw a stone because I'm from Jersey. We throw a boulder back.
Right. But I mean,
Don't,
his priority was a business. He wanted to run a big business, high revenue, and
right.
whether or not his patients were discerning enough to care whether
Yeah.
they had a crown that looked like yours or looked like his was
Right.
not really a big factor in his output, right? I mean,
And I don't, and I don't judge. Do what you want. Do what makes you happy. I mean, not to dismiss business, because one of the best things I ever did was get a business person to run my office, not someone in dental. I hired someone from the business world to be my office manager and run my business. And when she came in here, one of the first things she started looking at and go, why do you have this lease? Why are you doing this? Why are you doing that? Getting a business person to run your office is probably the best decision I've ever made. I don't want a dental person running my practice. I want a business person. So business is important. I also just value doing the best work I can for people.
yeah.
And some people, that's maybe not their goal. They want to just make bank and, you know, whatever. But I'm
Well,
not judging.
you're one of the fortunate ones, Dr. Pescatore, because you love dentistry and you want to focus on doing your thing, and you
Right.
still want to make money and pay your
Sure.
bills and take care of your family. So hiring that business person apparently was a good idea. I think that each individual dentist has to go into this field with their own viewpoint of what they want to get out of it, and they have to pursue
Absolutely.
that passion, whatever that passion is. Pursue it. If you want to do it as a business,
Absolutely. Go
hire
for it.
great doctors underneath you that do great work, and let them do the passionate dentistry and the conservative dentistry that the patient deserves. But if you want to do it yourself, then hire a businessman above you, or at least in line with you, that runs your business so that it's profitable. But you just have to pursue what your passion is and stick with it.
I agree totally. Absolutely. Couldn't have said it better, Phil.
All right, my friend. Thanks a lot, Dr. Pescatore. We'll see you on the next podcast.
Great. Thank you so much.
Folks, thanks for listening to our show. We do appreciate it. And I also want to say that if you are interested in hearing more tips and tricks from Dr. Pescatore, you can do that on vivalearning.com. Type in Pescatore in the search field and you'll find all his material. His name is spelled Pescatore. Have a great evening.